I would like to now invite Rebecka Peebles and Roxanne Rockwell to come up. There they are.
Do we need to be funny up here? I feel like
You do.
I know. It's a little intimidating. Hello.
Okay.
Hi. Do a dance.
So I'm Rebecka Peebles. I'm from the Children's Hospital of Philadelphia.
I'm Roxy Rockwell. I am a psychologist and director of the adolescent program at UCSD.
And so we're supposed to summarize one workshop for you guys on family challenges and family-based treatment. I want to just add a couple of things before we summarize that. With regards to what Jacinta was just talking about, I wanted parents, because I know that's a lot of the audience, to know that there was a woman who spoke after Jacinta, whose name was Shannon Calvert. Is she here today? No, okay.
Oh, she did so good.
I mean, she was unbelievable, and I think she is recorded online, Shannon Calvert, if you guys ever want to look up her talk, but not from yesterday, but from other talks she's given. But she is a survivor of an eating disorder and has undergone compulsory treatment, and her message to the audience was a quite clear, this, what the reason I'm here today, she closed with that. The two things that are here today, that are keeping me here today, are that I received compulsory treatment, but I received it with dignity, which sort of brings home the message that Jacinta was talking about. And it's definitely worth watching her online. It was impressive. And so for parents that ever worry that their children, adult children have to undergo compulsory treatment, it's really a hopeful message. The only other thing was that we're going to be talking about family-based treatment and conundrums and that. And Laura had told me to also summarize anything else I was in. I was in one workshop where we talked about sort of medical things to think about. I don't think that's that useful here. But there was one that we talked about using CBT, cognitive-based therapy, after cognitive behavioral treatment, rather, after family-based treatment in the community, because we do sometimes at CHOP have people that undergo family-based treatment and then still have OCD or social anxiety or things like that that still need to be worked on, or might have facets of their eating disorder that are still lingering despite a successful course of FBT. And we will work with some of our community partners to do CBT with those patients. And it was interesting to me how much controversy that brought up. We thought that we were only going to have like maybe 5 or 10 audience members, and the room was packed and with some really vocal forces in the field from the field of CBT who felt really concerned that the philosophies of these two treatments were somehow colliding and that this couldn't be done. So I just wanted you guys to understand that. I don't have answers to this, but we do use these two things successfully. I have to admit that I don't always think about the philosophical stance of things if they're working. And just know that while there are disagreements in the field and you may hear things from people, we can always be creative and things can always work.
Yeah, I'll just add, I know that there was a lot of talk yesterday about evidence-based practice and the way that you're able to incorporate your experience with the manuals. And when we're talking about FBT, we're not always talking about just the manual as it's written. We're talking about adding in CBT, parent management training, and a whole bunch of other strategies and skills from DBT as well. So it kind of incorporates all of that.
Yeah, and another thing that these manualized treatments, we don't view them as cookie cutter, those of us who use them. We view them as very much a vehicle for looking at the family as they are or the patient as he or she is, and their individual selves and the individual family, and gathering their strengths and helping them get better.
So the main thing we did yesterday in our panel, we had a bunch of fabulous experts, including myself and Dr. Peebles. So we went through a bunch of role plays. So we just acted out some of the difficult situations that come up with families. One being when the topic of a goal weight or a goal weight range comes up. We spent a lot of time on that one. Other ones
Are any of our family members here? Because we had some really great actors. JD, is she here? She was fantastic, I have to say, but I don't know who else is here.
Very good. Okay. So we talked about that for a bit. We talked about tension between the parents, and if it's a family with 2 homes, how you deal with that.
And how you deal with if families are struggling, if if someone seems stuck, or as a patient is getting more and more dysregulated, and families are worried that they might need to go to a higher level of care, how we talk through that if they do need to go, but also more importantly, how we talk through, can we still work on this at home? Can we regroup? Can we figure out what's stalling us? What's making things not work?
Daniel LaGrange left during my role play talking about higher levels of care, so I have to make sure he's not mad at me. Overall, I think everyone should start at the lowest level of care and only move up if necessary, just for the record.
Yeah.
So you said we have 1 minute left. Should we jump into questions?
Yeah. Any
Ready?
questions?
I've got a question.
Yes.
So it's not a question, it's hi, Roxy.
Hi.
I think one of the most important things I learned from you, Roxy, was tap out. If you're a parent that's just exhausted and done,
Yes.
just tap out.
And that's okay.
Someone else take over.
Absolutely. Yes. Thank you for bringing
We
that
can
up.
repeat that for the audience.
Yes, he was saying that one of the most important things that he learned is that it's completely okay to tap out. When you're done and you're about to lose your lid, tap out. If you have a partner, ask for help. Thank you.
Yes, sir.
You commented on the utility of CBT following FBT. How do you make a distinction between using CBT versus DBT after FBT?
Yeah.
With ACT and
I know. I mean, there are a lot of modalities. I think, I am a medical physician, so I don't make that decision. I go with what my behavioral colleagues say, but I will say that the kinds of things, we were specifically talking about CBT following FBT, like those are the only two we were covering, so it's not that we don't do DBT at times, but for the cases that we would do CBT, it would be someone with underlying OCD, PTSD, social anxiety disorder, which are there are modules that are specific for CBT treatment of those things. And it's only, again, we're only doing it when FBT is complete. And because a lot of those things are actually addressed during a good course of FBT, it's not that they're ignored, but so we're waiting and seeing where we're at, and then adding that on, and then there are times where we're following someone who really FBT isn't the right thing for them and their family, and of course that does happen, and then if we need to switch to CBT, how we make that decision and things like that. But so I'm not saying we don't use DBT, but it wasn't in the discussion yesterday. In my experience, and again, from a pediatrician perspective, it's usually more when someone is more dysregulated, having more difficulty with high and low emotions, and having trouble regulating their emotions and engaging in more risk behaviors. And that's usually when I would hear my colleagues say DBT should be thought about. Does that sound right to you?
yes.
Okay.
Another question.
There's a hand. Yes.
You mentioned that you advocate for the beginning at the lowest level of care. Can you say a little bit more about that and your reason?
Yeah, so in particular, I work with adolescents, and I feel like adolescents need to be at home with their families. So I think that going to something like a residential should be the last resort. It's definitely necessary sometimes, but I think everybody should start off with outpatient treatment if at all possible, if they're medically safe, and then move up if needed, if things aren't getting better.
Go ahead.
Yes. So I'm from a small city north of you, Scranton, and so what are you doing to make lower levels of treatment more available? Because we're really in a wasteland, and I don't think I'm unique in that situation. So just wondering, like working with local medical schools, providing more training. What are your thoughts?
We have so far to go still. I mean, we're definitely trying to do trainings as much as we can through UCSD. We do have a 5-day program in which families are able to come out, but again, not everybody has money to take time off of work and fly out to San Diego and spend a week. So we do try to incorporate telemedicine when we're able to, but again, psychologists can't practice across state lines, so we need to do more.
Yeah, we are. We're available for consultation from people for within a certain radius. It's consultation, though not treatment if they're outside of a 90-mile radius from us, or 30-mile actually, I think, from us. But we certainly will consult. We also we're working on telemedicine pilots. We've been developing some online interventions for primary care physicians to help recognize and intervene earlier, things like that. But I agree that there's a long way to go. I believe that bad therapy is worse than no therapy. Yeah. So when I got a call from parents it's not always a rural area, sometimes it's Boston or wherever, I mean, it can be all over the place, but if they cannot access someone who can work with them and work with their family in a respectful manner, then I guide them to Lauren Mulheim's book, Eva Musby's book, Laura Collins, and F.E.A.S.T. And I mean, that's what I guide them to, and I really try to empower them to pull themselves up and try to do this more on their own. I know that's really scary, and I'm not saying that's ideal, but it's better than working with a crummy therapist who undermines you.
Absolutely.
Wow. Thank you.